Ahlan biku. Today we're going to finish what we started, the larynx. Last time we talked about the general framework of the larynx, the cartilages and membranes and ligaments. And today we're going to talk about the cavities, the muscles, blood and nerve supply of the larynx. So let's start. The joints between the cartilages, you'll find two joints. The first one is the cricothyroid joint. It's between the lateral surface of the cricoid cartilage. Remember the facet we talked about on the lateral surface of the cricoid cartilage, and the inferior cornu or inferior horn of the thyroid cartilage. Remember we talked about this too. This is a direct joint between the two. It's a synovial joint. Synovial means it has a capsule, it has a synovial membrane and fluid. It's of the plain variety, which allows for the just gliding movements. And the gliding movements occurring in this joint is like the rocking action of the thyroid cartilage, forwards and backwards, forwards and backwards. Now, the thyroid cartilage, when it goes forwards, it tenses the structures attached to its posterior surface, like the vocal cord, for example. So it tenses the vocal cord, so it makes a sound of high-pitched sound. When it comes back towards the cricoid, it relaxes the vocal cords, so a low-pitched sounds. Actually, there is an operation surgery to adjust the tone of voice, working on this. Relying on this principle, like if a male with a rather thin voice, you can decrease the pitch of that voice by pushing the thyroid backwards and fixing it at that position. I've seen this. So this is the cricothyroid joint. The cricoarytenoid joint, between the shoulder of the cricoid cartilage and the base of the arytenoid on top. See that? This is the joint. It's synovial plane joint that allows for gliding movement, plane variety. Now, the types of movements here, the arytenoid can glide over the shoulder. Means that it abducts the cords, and also it can do a pivot movement, means it can turn counterclockwise or clockwise, also abducting or adducting the cords. This is the principal action of this joint and how the muscles work on this joint, like the posterior cricoarytenoid, for example. Now you can imagine the importance of abduction of the cords. Means that the rima glotidis, the space between the two vocal cords, is opened or closed. It's an important joint and important movement. So don't forget that, the abduction and adduction of the vocal cords, and the cricothyroid for tensioning or relaxing the vocal cords. And now let's talk about another subject, which is the cavity of the larynx. Of course, the cavity of the larynx, it opens upwards into the oropharynx, while continues downwards into the trachea. And the opening with the trachea is always open. Of course, it's not closed, never closed. But with the oropharynx, the opening can be closed by the movement of the epiglottis. Okay? Now, we're going to describe spaces, not structures. So please understand this. Spaces, we are talking about spaces, not structures, not physical structures. Okay? The first space or cavity is between, at the inlet of the larynx, between the aryepiglottic folds. Between the aryepiglottic folds. See? This is the inlet of The larynx, it's bounded anteriorly by the epiglottis and at the sides by the aeroepiglottic fold, posteriorly by the mucosal fold between the two arytenoid cartilages. This is the laryngeal inlet. It opens into the oropharynx, of course. Now, projecting into the cavity of the larynx are these two folds. See, this is the false vocal cord or the vestibular fold, and this is the true vocal cord, right? We are talking about folds because we are talking about mucosa. And there's a space between these two folds. Now, this protrusion of these two folds divided the cavity into three parts, three compartments. We have an upper chamber above the folds. We have a lower chamber below the folds. And we have a middle chamber, which is the ventricle between the folds, actually. Upper, middle, lower. The upper chamber is called the vestibule of the larynx. Vestibule of the larynx. While the middle chamber is called, on each side, it's called the laryngeal sinus. And all of them together, both of them together, they form the ventricle of the larynx. While the lower chamber below the true vocal cord is called the infraglottic cavity, or the lower chamber of the laryngeal cavity. Okay, so we have a vestibule, we have a sinus, and both of them, they form the ventricle of the larynx, and we have an infraglottic cavity. Okay, this is the cavity and how it's organized. The vestibule is between the area between the aryepiglottic folds and the vestibular fold. Aryepiglottic fold and the vestibular fold. Well, trust me, it looks simple, but when you encounter this information in an exam, it's rather difficult. So pay attention. It's between the aryepiglottic fold and the vestibular fold. This one, the vestibule. The sinuses, it's on the sides of the larynx. See that? See these two pouches of mucosa. Now, I want you to imagine that we're going through this laryngeal sinus anteriorly, okay, till we come to the back surface of the thyroid cartilage. Now, this cavity, the mucosa, extends upwards, may reach the upper limit of the thyroid cartilage in a sac called the laryngeal saccule. The laryngeal saccule, which is at the tip of the laryngeal sinus, extends upwards between the vestibular fold and the back of the thyroid cartilage. What do you think it has inside? It has mucus glands, numerous mucus glands. Why? To lubricate the cords. See, it's the lubrication for the cords. So don't forget, the laryngeal sinus extends anteriorly between the vestibular fold and the thyroid cartilage as the two laryngeal saccules arranged this way, one here and one there, at the front, of course, at the front of the epiglottis. Okay, this is important, the laryngeal saccule. Now for the openings. This is what you see in a laryngoscope. This is what you see in that. This is the epiglottis. This is the aryepiglottic fold. See that? And the corniculate and cuneiform cartilages, arytenoid cartilages here. And this is the true vocal cord. See that? The thyroarytenoid ligament, the true vocal cord. This is the true vocal cord. Now the space between, we said we're talking about spaces. The space between the two vocal cords is the rima glottis. Rima glottis. So the rima glottis closes and opens. Now, we said because of the attachment or the organization of the membranes inside the larynx, the vestibular folds will be in a position superior and lateral to the true vocal cords. These are the vestibular folds. See this one and this one. They are superior and lateral. They don't occlude the rima glottis. The space between the two folds is called the rima vestibuli. So the rima vestibuli lies superior to the rima glottis. All these are multiple choice questions in exams. The rima vestibuli lies superior to the rima glottis. Okay? Remember that. And the mucous membrane, of course, of the larynx also has mucous glands inside to lubricate wall movements of the vocal cords. Now you will be asked about the nerve supply of the vocal folds, not the vocal cords themselves. Remember, the vocal cord pushes the mucosa, so it has a superior surface and a medial surface, superior and medial surface at right angle. The superior surface and above of the vocal cord or vocal folds supplies sensation by the internal laryngeal nerve, while the medial surface and downwards sensation is taken out by the recurrent laryngeal nerve. So we have two nerves to take the sensations from the larynx. Above the vocal cords, or from the superior, because they will ask you about the vocal cord itself, vocal fold itself, the superior surface of it and above by the internal laryngeal, and the medial surface and below by the recurrent laryngeal nerve. And here you can see also the internal laryngeal nerve and superior laryngeal vessels entering, and these are branches of the recurrent laryngeal. See? We will see that in another specimen. Here is a diagram of the laryngoscope. See the true vocal cords here and the false vocal cords, okay? And remember the position. Actually, this scene shows the laryngeal inlet, the rima vestibuli, and the rima glottis. Okay. Now, another subject, the muscles of the larynx. They are classified into extrinsic muscles and intrinsic muscles. Extrinsic muscles means that they work on the whole device. Means that they either pull the device up or down. We've taken this, we've studied this. What do you think the muscles that raises the larynx or the muscles that depresses the larynx? Of course, the suprahyoid muscles and the infrahyoid muscles. We studied these muscles, the digastric, the mylohyoid, the genohyoid. Remember these muscles. These act on the larynx by exerting their action on the hyoid bone, which is connected to the larynx by membranes and joints. So these are the extrinsic muscles, and of course they have different nerve supply for each muscle. They have their own rule. Now, the intrinsic muscles means that they control phonation, control the inlet of the larynx and voice production. These are the intrinsic muscles. It doesn't mean that they lie within the larynx, because we have a cricothyroid muscle that's located outside the larynx, but it acts on the vocal cords. So it is an intrinsic muscle. It's not related, the term intrinsic, it's not related to their position. It's related to their action. What do they do? Okay, muscles that control the inlet means that they either close the inlet or open the inlet. The openers are posterior cricoarytenoid and thyroepiglotticus. The posterior cricoarytenoid, this is the posterior cricoarytenoid, see? It originates on the back surface of the cricoid and goes to the muscular process of the arytenoid. Imagine you pull on that muscle, it abducts the vocal cord. Actually, this is the most important muscle in the body, the posterior cricoarytenoid, because paralysis of this muscle, especially at the two sides, is fatal. Posterior cricoarytenoid muscle. Remember this muscle, and you will be asked about this muscle. The posterior cricoarytenoid. Remember the term posterior because there is a lateral cricoarytenoid, which has the opposite action. It adducts the cords. Okay, so this is the abductor of the cord. The thyroepiglotticus, on the sides, there is a muscle called the thyroarytenoid. It's not apparent here. The upper part of it extends to the epiglottis, aryepiglottic fold, so it's called the thyroepiglotticus. We will see it in another slide. It opens the laryngeal inlet. Now, closers of the laryngeal inlet are these muscles. See, this is the transverse arytenoid muscle, and oblique arytenoid muscle. The transverse arytenoid or transverse interarytenoid muscle, this one, and the oblique muscle. See, the oblique muscle is not limited to the back surface of the arytenoids. They extend upwards in the aryepiglottic fold as the aryepiglotticus muscle, which closes the inlet. Okay? They are continuation. This is another question. The aryepiglotticus is a continuation of the oblique interarytenoid muscle, which closes the inlet as well. Okay? Okay. Now, muscles that control the glottis means the rhemoglotidus. They either adduct the cords or abduct the cords. The openers or abductors of the cords, the only muscle we said is the posterior cricoarytenoid. It abducts the cords, right? And closers of the cords or adductors of the cords, like the oblique and the transverse arytenoids, lateral cricoarytenoid. Now, the lateral cricoarytenoid is present on the lateral side between the arch of the cricoid and the arytenoid process. Lateral cricoarytenoid. It's not apparent here in this slide. Don't confuse the two muscles, please, the lateral and posterior, because they oppose each other. They have different actions. Muscles that control the tension of the vocal folds means they tense or relax the vocal folds. What do you expect the movement that tenses the vocal folds? Yes, forward rocking movement of the thyroid cartilage, like the cricothyroid muscle and the posterior cricoarytenoid muscle. The cricothyroid, by acting on the thyroid cartilage, it tenses the vocal cord. But the posterior cricoarytenoid, by acting on the muscular process of the arytenoid, they relax the vocal cord by their tension because they come from posterior aspects, so they pull the arytenoids towards them. So it's like relaxing the cords, okay? Other muscles related to directly to the vocal cords are the thyroarytenoid and vocalus. Thyroarytenoid in the fold itself, in the vocal fold itself, and vocalus as well. Now, if they run parallel to the vocal cords, so when they contract, they will actually relax the cord. They will not tense it. Imagine the cord with a muscle beneath it, along it, so parallel to it. So when this muscle contracts, the cord will contract as well. I mean shorten. It will not be tensed no more. Okay, I know it's difficult to distinguish the names from the actions, but with practice, you will go through this. But please stress on the posterior cricoarytenoid and the transverse, intertransverse and oblique, and the lateral cricoarytenoid. As simple as that. These are the muscles that you frequently see in multiple choice questions: the posterior cricoarytenoid, the transverse oblique, and the lateral cricoarytenoid. See, this is from the lateral surface. See, this is the cricothyroid muscle cut here. This is the cricoid cartilage. Okay, this is anterior, this is posterior. How did I know? First, from the hyoid bone, this is the great cornea going backwards. This is the lamina of the cricoid cartilage, which is posterior. So this is the cricothyroid. It's from the outside, the cricothyroid. You can see remnants of it here. Cricothyroid. When it pulls on the thyroid cartilage, it will tense the vocal cord, as we said. Now, there's another muscle here apparent, which is the cricoarytenoid muscle. See that? Cricoarytenoid muscle. There is the thyroarytenoid muscle, and the upper part of this muscle, actually it's not drawn here, but when you remove all the mucosa, you'll find extension of this muscle upwards to the aryepiglottic fold. It's called the thyroepiglotticus. The thyroepiglotticus is the upper part of the thyroarytenoidus muscle. Thyroepiglotticus is the upper part of the thyroarytenoidus muscle. And this is the aryepiglotticus muscle, which is a continuation of the oblique interarytenoid muscle. See that? It's very well shown here. Okay. This is another specimen to show the cricothyroid muscle. See, this is the cricothyroid muscle with a branch of the external laryngeal nerve actually supplying the muscle. This is the exception. All muscles are intrinsic, now be careful here. Not all muscles of the larynx, all intrinsic muscles of the larynx are supplied by recurrent laryngeal nerve, except the cricothyroid, which is supplied by the external laryngeal nerve. See the trap here in MCQ? Now the problem with multiple choice questions, the bad part is they do not test only your information, they test your grammar. So if they start the question with all the muscles of the larynx are supplied by such and such, it's completely different than all intrinsic muscles are supplied by such and such, okay? Pay attention to this. This is the cricothyroidus muscle with its nerve supply. Okay, this is another specimen, live specimen. The oblique interarytenoid muscle and the transverse. Very well apparent here. This is the posterior cricoarytenoid, and a beautiful dissection of the nerve and blood supply of the larynx. See, this is the internal laryngeal nerve piercing the thyrohyoid membrane with the superior laryngeal artery. It's beautiful dissection here, this side and this side. So what do you call this space? Remember this recess? Exactly, the pyriform recess. This is the pyriform recess. Okay, they are continuous upwards through, remember that structure in the oropharynx? The vallicula, exactly. So the vallicula and continuous on each side with the pyriform recess. And these are branches of the recurrent laryngeal nerve and inferior laryngeal vessels to supply the inside of the larynx. This is a beautiful specimen to demonstrate. Okay, 2 points worthy of mentioning. I told you that the oblique arytenoid muscles continue as the artery epiglotticus, and the thyroarytenoid muscle, its upper part, is the thyroepiglotticus. Okay? Don't forget these two pieces of information. Okay, we are done with all the names and structures. What are the functions of the larynx? Of course, respiration, of course, phonation, and effort closure means to trap air inside to increase the inside pressure, like in straining, during carrying weights, or during defecation, for effort closure. That's why by the end of the effort closure, one gets a grunt coming out of the larynx because of the sudden opening of the vocal cords. Another point worthy of mentioning, that during swallowing, the larynx moves upward and forwards, bringing the glottis down against inlet. Of course, this is logic. Doesn't need any explanation. Now, there are certain procedures that you should be aware of, like the laryngoscopy. There's a special device to depress the tongue, and this occurs under anesthesia, by the way, and introduce a laryngoscope. The laryngoscope introduced through the mouth, and you can introduce it down till you see. Remember the scene of the rima glottis and rima vestibuli. This is the scene you will be seeing. Now, I think we have mentioned the tracheostomy and cricothyrotomy before. The cricothyrotomy, remember, we said that last time that it's a procedure, it's an emergency procedure that you go through the median cricothyroid ligament, remember? Median cricothyroid ligament. You feel the laryngeal prominence and you go down till the end of the thyroid. You feel a depression, then another elevation, which is the cricoid. Now, in this depression between the thyroid and the cricoid, you puncture with a knife or something, any sharp instrument, to establish an immediate airway. Of course, this is an emergency procedure. They don't do that in hospitals. This is called the cricothyrotomy. It's just an emergency till the patient is translocated to a hospital. The tracheostomy is an OR, operating room procedure. Now I want you to tell me, actually they introduce a device through the trachea rings inside the trachea. Means below the cricoid cartilage, in the trachea proper. Now, I want you to think about structures that you will be dealing with to reach the trachea from front. Below the cricoid, what do you think the structures you will pass through? Skin, of course, fascia, platysma. Then, the infrahyoid muscles, exactly. But to be precise, which of the following muscles will be you will be dealing with? The thyrohyoid or the sternohyoid? Sorry, the sternothyroid or the sternohyoid? We said this information with the infrahyoid muscles. Now we are low down. Remember, the sternothyroid, lower down, is medial, while it goes upwards and lateral, while the sternohyoid, lower down, is lateral, and it goes upwards and medial. Okay? And since we are at a lower position, we will be dealing exactly with the sternothyroid muscle. Now, after you expose the sternothyroid, and remember we said that when you cut, don't try to cut the muscles at a very low level. Go as high as possible to cut it. Now, what else you will be dealing with, especially opposite the second, third, fourth tracheal rings? Exactly, the isthmus of the thyroid gland. Exactly, correct. So you will be dealing with skin, fascia, platysma, infrathyroid muscles, and then the isthmus of the thyroid gland till you reach. This is a procedure that you can't do on the streets as emergency. Till you reach the trachea and fix the tracheostomy tube. It's a procedure you will encounter with cancer larynx patients, especially cancer larynx patients. Now, the vessels, blood supply and venous drainage. It's very easy. From superior and inferior laryngeal arteries. This is the superior laryngeal artery. This is branches of the inferior laryngeal artery. And the names correspond to the arteries that they gave them. The superior laryngeal comes from the superior thyroid. Inferior laryngeal comes from the inferior thyroid. It's very easy to remember. Okay, now how do they find their access to inside the larynx? The superior laryngeal artery pierces the thyrohyoid membrane, while the inferior laryngeal artery goes beneath the cricopharyngeus. Remember, the inferior constrictor goes inside the larynx beneath the inferior constrictor or the cricopharyngeus part of the inferior constrictor. And each vessel is accompanied by a nerve. Right, yes, the superior laryngeal artery accompanied by the internal laryngeal nerve, while the inferior laryngeal artery is accompanied by the recurrent laryngeal nerve. The veins accompany the arteries, see that? The superior laryngeal to superior thyroid and eventually to the internal jugular vein, while the inferior laryngeal with the inferior thyroid and eventually into the left brachiocephalic vein. Exactly, we said the left brachiocephalic because it's almost horizontal in course and longer than the right brachiocephalic. It takes both inferior thyroid veins with it. Don't forget that. Okay? The lymphatics eventually to the deep cervical lymph nodes opposite the course of the arteries. The nerves, we said, the internal laryngeal nerve. Now there's a branch from the vagus called the superior laryngeal. Remember what we said about the superior laryngeal branch of vagus in the carotid triangle? Well, we said it at the end when we organized the structures, when we put the structures together in the carotid triangle. Yes, it is the deepest structure in the carotid triangle. It goes down from the vagus and divides into internal and external laryngeal. The external laryngeal remains on the sides of the pharynx, supplying and ends by piercing the inferior constrictor and supplying the cricothyroid muscle. This is the external laryngeal. While the internal laryngeal pierces the thyrohyoid membrane and goes with the superior laryngeal artery to supply the inside of the larynx. Now, the pattern of supply, the internal laryngeal nerve is sensory to the area from the superior surface of the vocal cord, through vocal cord, from the superior surface upwards till the inlet. And the recurrent laryngeal nerve, the medial surface of the vocal cord downwards, sensation from the larynx. Okay, so remember this. They both supply the vocal cord, but the recurrent laryngeal, the medial surface, and the superior laryngeal, the superior surface of the vocal cord. The upper part of the larynx carried by the internal laryngeal nerve, while the lower part of the larynx by the recurrent laryngeal nerve. This is regarding sensations. But the motor supply, we have a rule. All intrinsic muscles of the larynx are supplied by the recurrent laryngeal nerve, except the cricothyroid, which is supplied by the external laryngeal nerve. Don't forget this. Okay, this is another diagram showing the internal laryngeal nerve and the superior laryngeal artery here, and the recurrent laryngeal with the inferior laryngeal artery. It's a beautiful drawing here. Now, when we talk about the recurrent laryngeal has a different story on each side. On the right side, they both, of course, come from the vagus, but on the right side, it loops around the subclavian artery, while on the left side, it loops lower down around the arch of the aorta. You will be asked, trust me, I got this question, which is longer, the right or left recurrent laryngeal nerves? Of course, the left recurrent laryngeal. This is the British style of questions. These fine details. Okay? The left recurrent laryngeal is longer than the right recurrent laryngeal. The left recurrent laryngeal arises in the thorax, while the right recurrent laryngeal arises at the root of the neck. Exactly. So, they are both from the vagus. They loop around vessels and go up. That's why they are called recurrent, because they go back upwards to the larynx. We said the supply, sensory and motor. And a point worthy of mentioning here, that neck lesions can cause hoarseness of voice if they were on the, what do you think, right or left side? Right side. Of course, on both sides, if there is a lesion between the trachea and the esophagus, because the recurrent laryngeal runs between trachea and the esophagus, they will be affected. But I'm talking about the point of origin. If there's a lesion near the first part of the right subclavian artery, it may affect the right recurrent laryngeal nerve. If there's a lesion between the arch of aorta and pulmonary trunk, imagine in the thorax, lower down, the patient may suffer from hoarseness of voice if it was on the left side. Not specially on the left side, no, only on the left side, because there is no recurrent laryngeal on the right side in the thorax. You can see, tricky questions. So lesions in suppose tumors or something between the arch of the aorta and left pulmonary trunk may cause hoarseness of voice. بحة صوت. تغير في الصوت. Okay, last not least, the recurrent laryngeal nerve, when they studied the arrangement of fibers in the recurrent laryngeal nerve, they found out that the nerves, the motor fibers, they are on the surface and they are more numerous than the sensory fibers. So the recurrent laryngeal nerve almost motor, because it's motor to all the intrinsic muscles of the larynx. These fibers, the motor fibers, are on the surface. Means that if you are operating on the thyroid gland, for example, you know, as each handling by the forceps of the surgeon of the recurrent laryngeal nerve destroys some fibers. Imagine that. When you grasp the recurrent laryngeal nerve with the forceps, be as gentle as possible, or try just to push it away from the field. Don't grasp it, because the motor fibers are on the surface and they may be destroyed. And this is what they call the partial injury of the recurrent laryngeal. Partial injury means that it's not cut, it's not severed. Only the surface fibers are destroyed. And what's on the surface? The motor fibers, exactly, not the sensory fibers. These drawings here represent the vocal cords in the abducted form in the normal position. See, this is the midline. The cord away from the midline is abducted, towards the midline is adducted. See, the normal abduction is perfect, nothing wrong with that. Now with partial injury, we destroyed the motor fibers on one side, for example. Now that side will lose its abductor, right? Means that because also the abductor fibers are on the top too, means that the other side will take over, right? The adductors will take over. So the cord will be adducted to the midline. See? Okay. This is a unilateral when it's only on one side. Complete injury of the nerve means it's cut or severed. The cord will not be adducted, neither abducted. It will be just hanging there midway. See, midway between adduction and abduction. Midway, hanging there. No action in the cord. You cannot abducted or adducted. The voice will get weakened. That's it. Weak voice. Okay? Now, if bilateral nerve injury, the partial injury is more dangerous than the complete injury. The partial injury, you are destroying the fibers for the abductors of the cord mainly because they are more on the surface. This is the arrangement of the surface. This is the arrangement of fibers. So both cords will be adducted to the midline. Adducted to the midline means you are closing the hemoglotitis. This is a fatal condition. It's an emergency. Okay? And maybe a post-surgical consequence, bad consequence of if of course no surgeon cuts both nerves or either one nerve, but we're talking theoretically if these are cut in a neck injury, for example. Okay, complete injury on both sides. Both cords will be hanging midway between abduction and adduction. It's not dangerous because the hemoglotitis is open, but there will be no speech. The patient will not be able to speak. Well, this concludes the larynx, and this concludes the actually this part of the neck. And as I told you before, I prefer to continue with the airway. Means that we will go up and study the nasal cavity next time to conclude the upper airway as we are done with the upper food way or digestive way. Thank you very much for watching.